golden notes. Acute pancreatitis. Acute pancreatitis accounts for 3% of all cases of abdominal pain admitted to hospital. It affects 2 to 28 per 100,000 of the population and is increasing in incidence. It is potentially serious condition with an overall mortality of 10%. About 80% of all cases are mild and have a favorable outcome. Approximately 98% of deaths from pancreatitis occurs in the 20% of patients with severe disease, and about 1/3 of these arise within the first week, usually from multi-organ failure. So what is the acute pancreatitis? It is acute inflammation of the pancreas, results in release of exocrine enzymes that cause autodigestion. Pathophysiology: sequence of events leading to pancreatitis. Intrapancreatic activation of pancreatic enzymes secondary to pancreatic ductal outflow obstruction, like gallstones or cystic fibrosis, or direct injury to pancreatic acinar cells, like alcohol or drugs. Enzymatic autodigestion of pancreatic parenchyma and attraction of inflammatory cells like neutrophils, macrophages, so release of inflammatory cytokines, and then pancreatic inflammation. The sequelae of pancreatitis: capillary leakage, which lead to hypotensive tachycardia and then distributive shock. There is a shift of fluid from intravascular space into the interstitial space, which means a third space loss, because releasing of inflammatory cytokines and vascular injury by pancreatic enzymes leads to vasodilation and increased vascular permeability. Also, there is a pancreatic necrosis and a hypocalcemia. The lipase breaks down peripancreatic and mesenteric fat, then release of free fatty acids that bind calcium, then it leads to hypocalcemia. Now, the causes of acute pancreatitis: in fact, the vast majority of cases in the UK are caused by gallstones and alcohol. There is a kind of popular mnemonic for remember the causes of acute pancreatitis, which is get smashed. G for gallstone, E for ethanol, T for trauma, S for steroids, M for mumps, A for autoimmune or ascaris infection, S for scorpion venom, H for hypertriglyceridemia, hypercalcemia, hypothermia, E for ERCP, which is the acute pancreatitis following ERCP, that should be treated with IV fluids and analgesia. ERCP is the third commonest cause of pancreatitis after alcohol and biliary tract disease. D for drugs: azathioprine, mesalazine, corticosteroids, fibrates, omega-3 fish oils, thiazide diuretics, pentamidine, furosemide, and sodium valproate. In fact, pancreatitis is 7 times more common in patients taking mesalazine than sulfasalazine. In fact, hypertriglyceridemia considered a risk factor for pancreatitis when triglyceride levels are above 11.2 millimole per liter, which is about more than 1,000 of triglyceride milligram per deciliter. In a patient with hypertriglyceridemia and acute abdominal pain, an amylase should be checked to exclude acute pancreatitis. And remember that pancreatitis secondary to hypertriglyceridemia has greater severity and is associated with a higher complication rate. Features: the typical presentation is with severe, constant upper abdominal pain of increasing intensity over 15 to 60 minutes, which radiates to the back. Nausea and vomiting are common. There is marked epigastric tenderness, but in the early stages, and in contrast to a perforated peptic ulcer. Guarding and rebound tenderness are absent because the inflammation is principally retroperitoneal. Bowel sounds become quiet or absent as paralytic ileus develops. In severe cases, the patient becomes hypoxic and develops hypovolemic shock with oliguria. Discoloration of the flank, gray Turner's sign, or the periumbilical region, the Collins sign, is a feature of severe pancreatitis with hemorrhage. The differential diagnosis includes a perforated viscous, acute cholecystitis, and myocardial infarction. Various complications may occur, and these are systemic complications like systemic inflammatory response syndrome, SIRS, hypoxia, hyperglycemia, hypocalcemia, and reduced serum albumin concentration. There are other pancreatic complications like necrosis, abscess, pseudocite, pancreatic ascites, or pleural effusion. Also, some gastrointestinal complications like upper gastrointestinal bleeding, variceal hemorrhage, erosion into colon, duodenal obstruction, and obstructive jaundice. The diagnosis is based on raised serum amylase or lipase concentrations and ultrasound or CT evidence of pancreatic swelling. Plain X-rays should be taken to exclude other diagnoses such as perforation or obstruction and to identify pulmonary complications. Amylase is efficiently excreted by the kidneys, and concentrations may have returned to normal if measured 24 hours to 48 hours after the onset of pancreatitis. A persistently elevated serum amylase concentration suggests pseudocite formation. Peritoneal amylase concentrations are massively elevated in pancreatic ascites. Serum amylase concentrations are also elevated, but less so in intestinal ischemia, perforated peptic ulcer, and ruptured ovarian cyst, while the salivary isoenzyme of amylase is elevated in pancreatitis. And if available, serum lipase measurements are preferable to amylase as they have greater diagnostic accuracy for acute pancreatitis. Ultrasound scanning can confirm the diagnosis, although in the earlier stages the gland may not be grossly swollen. The ultrasound scan is also useful because it may show gallstones, biliary obstruction, or pseudocite formation. Contrast-enhanced pancreatic CT performed 6 to 10 days after admission can be useful in assessing viability of the pancreas if persisting organ failure, sepsis, or clinical deterioration is present, since these features may indicate that pancreatic necrosis has occurred. In fact, necrotizing pancreatitis is associated with decreased pancreatic enhancement on CT following intravenous injection of contrast material. The presence of gas within necrotic material suggests infection and impending abscess formation, in which case Percutaneous aspiration of material for bacterial culture should be carried out and appropriate antibiotics prescribed. Involvement of the colon, blood vessels, and other adjacent structures by the inflammatory process is best seen by CT. Serial assessment of CRP is a useful indicator of progress. A peak CRP of more than 210 mg per liter in the first 4 days predicts severe acute pancreatitis with 80% accuracy. It is worth nothing that the serum amylase concentrations has no prognostic value. You can also use Ranson's criteria on admission and after 48 hours. There are also something called the Glasgow criteria for prognosis in acute pancreatitis, and also the Apache score. So as a brief talking, the complications are ARDS, acute kidney injury, and DIC and pancreatic pseudocide. Investigations: tests to confirm clinical diagnosis, amylase, lipase, and to assess severity, hematocrit, white blood cell, blood urea nitrogen, and CRP and ALT. For images, ultrasound, the most useful initial test, and CT and abdominal X-ray. The management: fluid resuscitation, aggressive hydration with crystalloids, analgesia, IV opioids like fentanyl, and bowel rest MBO and IV fluids are recommended until the pain subsides. Nasogastric tube insertion: it is not routinely recommended, indicated in patients with vomiting and or significant abdominal distension. Nutrition: begin enteral feeding as soon as the pain subsides. Total parenteral nutrition only in patients who cannot tolerate enteral feeding. For example, those with persistent ileus and abdominal pain. If there is gallstones, then urgent ERCP when stable. All should have a cholecystectomy either during the same admission or within 4 weeks, depending on their clinical progress. This was provided by the SSSM Study Smart series for Mrcp, your easy way to easy pass. Remember that the references and sources for the Golden Notes are Davidson, Oxford Handbook Series, Essential Revision Notes for Mrcp, and Notes and Notes. Don't forget to follow us on Facebook, Telegram, and YouTube channel. And remember, with SSSM, you're always in a safe zone, and you're always the winner. Thank you very much.